Good morning. It's a great pleasure to introduce Dr. Mari Kaliswar. She's our fourth-year resident. Mari did her PhD in liver transplantation in the UK, and she joined our team to continue her clinical residency. I'd like to welcome also Professor Pfammatter from Interventional Radiology, Professor Zimmermann from Vascular Surgery, and Professor Al-Qadri from Diagnostic Radiology, who join us for the interdisciplinary discussion led by Professor Turina.
Yes, good morning everyone. So today I'll discuss acute mesenteric ischemia. First, the case presentation. It's one of the cases we've seen a couple of from the last few months. It's a 58-year-old female on intensive care. She had a severe case of COVID-19 with multi-organ failure. She had been intubated for 14 days on ITU with this severe CT thorax image. And then after these 14 days, a sudden clinical deterioration occurred with liver failure, myocardial infarction, resulting in cardiac arrest. She then was successfully resuscitated, but afterwards a lactate acidosis and a distended abdomen was observed, so an abdominal CT was made. On this CT, we saw the intestinal pneumatosis, so there was a suspicion of bowel ischemia, but actually all the visceral vessel, artery and veins were open. So is there acute mesenteric ischemia, and what type of ischemia would it be? Does any of the residents has an answer to this question?
I think we can divide in between the occlusive ischemia and the NOMI and non-occlusive mesenteric ischemia, for example.
Mm-hmm. Yes, this is a case of, because the visceral vessels are open, this is a case of non-occlusive mesenteric ischemia. So what is the management? What would you suggest we do?
I think in this case, where we have no signs for an occlusion, we should go for a urgent laparotomy.
Yes, that's correct. We have an unstable patient on ITU with a difficult clinical examination because she was sedated, but the abdomen is distended, and we also have the lactate acidosis. So a prompt laparotomy was performed. The intraoperative findings were 1 meter after trite, or the duodenal jejunal junction. There were 5 meters of small bowel with partial transmural necrosis and also high-grade ischemia. So this part of the bowel was resected, jejunostomy was made, and also an abdominal vacuum system was inserted. Then a second loop was planned in 24 to 36 hours. But actually after this operation, the patient did not stabilize, and there was a worsening multi-organ failure, and she actually died 2 days after surgery despite maximum treatment. And she was not the only patient with COVID-19 that this happened to in the last couple of months in our clinic. So this was just an example of what we see in our clinical practice. Further this presentation, what I'll discuss today is the clinical presentation of acute mesenteric ischemia, the anatomy and pathophysiology, the classification, diagnosis and management. So first, what is acute mesenteric ischemia, or the AMI? It actually refers to the sudden onset of intestinal hypoperfusion, which can be due to the reduction or cessation of blood flow. Types of AME. Lauren actually already discussed it. We have 4 types. We have the occlusive AMI, which can be embolic or thrombotic, the non-occlusive AMI, which the patient was suffering from, and also the mesenteric vein thrombosis, so which is a venous problem of the portal system. So first, the anatomy. Here you can see the anatomy of the small bowel and large bowel. On the left side, first is the superior mesenteric artery, which supplies the small bowel, and also the left or the right-sided colon and the transverse colon. Then the inferior mesenteric artery, which supplies the left-sided colon, the sigmoid, and also the rectum. And then the venous anatomy, you can see the right colon and the small bowel are perfused or are drained by the superior mesenteric vein. The left-sided colon and the sigmoid and the rectum are drained by the inferior mesenteric vein, which then comes together with the splenic vein, and they confluate with the SMV into the portal vein. And then we have 3 watershed areas. These watershed areas are parts of the body that have two-sided perfusion, which can be an advantage in case the perfusion is stopped to one side of the arterial system, but can also be a problem in states of hypoperfusion, but because these areas are actually at the distal end of the arterial perfusion, so then they are the most vulnerable. In the abdomen, we have on the right side we have the Rio Branco arcade, which is a natural anastomosis between the celiac trunk and the superior mesenteric artery. We have the Rialin anastomosis, which is the anastomosis between the SMA and the inferior mesenteric artery, with the middle colic artery and the left colic artery, and also the Sudeck anastomosis between the sigmoid artery and the iliac internal artery. Then the pathophysiology, which is also important here. You can see the layers of the bowel from outside to inside. We have the serosa, the muscularis layer, the submucosa, and the mucosa. The pathophysiology, it all starts with the deficit or the hypoperfusion, so lower blood supply or drainage. This causes insufficient bowel perfusion. Then there's tissue hypoxia. This leads to abnormal drainage of metabolites. It also leads to a loss of bowel wall integrity and then bacterial translocation. This can already cause a sepsis and septic shock, but if then also a perforation occurs with peritonitis or abscess, this process will even accelerate. Then the clinical presentation. What's important here there's an acute onset of severe abdominal pain, which is out of proportion to the actual clinical findings in the beginning of the condition. So a patient will have severe pain, but an abdomen might not be distended or an acute abdomen yet. Patients that present like this, an acute mesenteric ischemia should always be assumed until proven otherwise. So next to the abdominal pain, these patients can also present with nausea and vomiting, diarrhea, and sometimes also blood rectum. Then there are 3 phases which the disease presents itself. The first 6 hours, there's a hyperactive phase where there is this discrepancy between the strong pain and the clinical findings. The next 6 hours, there's the paralytic phase when there is a distended abdomen and reduced bowel sounds. And after 12 hours, the septic phase will start to develop due to volume leakage, and we have the acute abdomen and the septic shock will occur. Also here the mortality, as you can see in this diagram, the time of ischemia that before a treatment is started is has a close relation to the mortality. And you can see that even if treatment is started within 12 hours, there still is a mortality of 1/3, and this increases quickly. And even after 24 hours, 80% of the patients will die. When a patient has an acute abdomen, if you have the suspicion of acute mesenteric ischemia, also of course there can be other causes that can cause these severe abdominal pain, and these other cases should be excluded because they are also severe and should be treated immediately, like pancreatitis and aortic aneurysm that has ruptured or is close to rupture, or a gastrointestinal perforation like with a peptic ulcer or diverticulitis. The classification of acute mesenteric ischemia. So what I said before, we have the 3 types of occlusive mesenteric ischemia, non-occlusive, and the mesenteric vein thrombosis. The occlusive mesenteric ischemia is the most common, with 60%, that it can be divided into the embolic and thrombotic ischemia. The 1/3 of the cases is the non-occlusive ischemia, and 10% is the venous thrombosis. It's important that it's a rare condition, but with less than 1% of the acute surgical admissions. So risk factors, they all actually depend on the type of ischemia. And the arterial embolism, risk factors for that are like a recent myocardial infarction due to a ventricular thrombus or an arrhythmia like atrial fibrillation. The arterial thrombosis is more common in patients with the systemic atherosclerosis. The non-occlusive mesenteric ischemia, or the NOMI, we see that in patients with cardiogenic shock or any type of shock where vasopressive agents are used, or sepsis. And the mesenteric vein thrombosis We see that often more often in patients with hypercoagulability or portal hypertension. So the mortality of AMI, it's not only the time is important in this disease, but also what type of ischemia we have. And the most deadliest is the occlusive mesenteric ischemia, where 3/4 of the patients have a chance or die during the process. NOMI has the mortality is a little bit lower, and the mesenteric vein thrombosis, more than 50% of the patients are likely to survive. Over the last decade, what is important, there has been no significant reduction in hospital mortality. So now I go more into the type of AME that we have. First, the embolic occlusive ischemia. The origin, what I said before, it's often from the left atrium due to atrial fibrillation, or the left ventricle with a thrombus. And the location, most of the time it's located in the SMA, the superior mesenteric artery, because it has a wide diameter and also a small angle compared to the aorta. So it's a good, and this embolus, most of the time it will be located 3 to 10 centimeters distal to the SMA origin, and therefore in most of the cases the proximal jejunum will be spared. In 20% of the cases, additional emboli are also seen in the splenic artery or in the renal artery. Then the thrombotic occlusive ischemia. This is seen in patients with generalized atherosclerosis or hypercoagulability, and it's more often located at the origin of the vessels of the SMA and also the celiac axis, because these patients will before already have their thrombotic plaque at these locations. These patients, here it's important that in their history they describe a more chronic mesenteric ischemia, that they had fear of food for a longer time. Then we go to the non-occlusive ischemia. This has a relation to the hemostatic mechanism, because in case of insufficient perfusion, what we see in these cases is that there's an insufficient perfusion, but the vessels are actually still open. And this is because when there is a systemic hypotension, the body will first actually maintain the cardiac and cerebral blood flow, and this is at expense of the splanchnic and peripheral circulation. Risk factors for NOMI are heart failure, cardiogenic shocks, can also be cardiac arrhythmias, septic shocks, the use of vasoconstrictive medications, cardiopulmonary bypass, severe burn injury, and chronic renal failure. And also what we saw with the clinical case is in case of a severe infection and a systemic disease with the COVID-19. And these are the patients that we often get a consultation to in the middle of the night of ITU, that we have to consult the patient and see if a laparotomy is required. Then third and the last, the mesenteric venous thrombosis. Here, virchostriad, which you all know is important. There's reduced flow, there's an increased coagulability and endothelial injury. And these three factors are very important in the development of a thrombus. And we see this hypercoagulability in cases of protein S and protein C deficiency, in patients with an antithrombin deficiency, and also the antiphospholipid syndrome, which can be seen in lupus, and also secondary in patients with portal hypertension, inflammatory bowel disease, pancreatitis, or any form of sepsis. So the diagnostics for acute mesenteric ischemia, first it's important, laboratory tests are very non-specific. We often see raised white cell counts, an acidosis, an elevated CK and lactate, and also dedimer, but this can be the result of any kind of severe disease. Imaging, it's very important that an abdominal CT with triple vascular phase is performed without any delay. This test is actually has a high sensitivity and also high specificity, and it will not only you can diagnose an acute mesenteric ischemia, but it also exclude other cases for acute abdominal pain that should be treated as well. And then the findings on imaging for every type of ischemia. First, for the embolism, you will see an occlusion of an artery. In case of the thrombotic ischemia, there most of the time is also diffuse atherosclerotic disease. In case of NOMI, had a non-occlusive disease, there's bowel ischemia, but the vessels are open. And in case of mesenteric venous thrombosis, there's a thrombus in the SMV or the portal vein. Then a secondary symptom of this bowel ischemia is the intestinal pneumatosis, which can be seen in other diseases as well, but it's worrisome if it's combined with soft tissue bowel wall thickening, free intraperitoneal fluid, or periintestinal soft tissue stranding, and also if there's an abnormal bowel wall enhancement. These pictures actually show late signs of intestinal pneumatosis. Does any of the residents can name what we see here on the pictures?
So maybe the first, there are gas, mesenteric gas, superior mesenteric vein gas, and portal vein gas.
Yes, that's correct. Thank you. So then we go to the management. The first management is resuscitation. Fluid should be given rapidly to enhance visceral perfusion, also correct electrolytes and the metabolic acidosis. Broad spectrum antibiotics should be started, and also anticoagulation. Sometimes it can, if you decide to go to a quick laparotomy, to give the anticoagulation afterwards. And how do you then proceed? Well, here it is important if on the clinical examination, if there's a peritonitis or not. If there's peritonitis, there's no time and a prompt laparotomy should be performed. If there's no peritonitis, you have some time, it's not a lot, but there's a role for immediate revascularization procedures in case of a partial arterial occlusion. Most of the time, this in these days will be an endovascular approach. So in patients with peritonitis, the surgical management is the prompt laparotomy. During the laparotomy, clearly non-viable bowel should be resected. And in sometimes you also see that the bowel is not like clearly non-viable, but the perfusion is not optimal as well. And then relook can be planned. If a reperfusion potentially is possible, most of the time it will be an endovascular approach. In the case of occlusive ischemia, an open a thrombectomy or embolectomy can be performed, or PTA with stenting in a hybrid operation. In case of non-occlusive ischemia, of course, reperfusion is not an option, and in case of mesenteric vein thrombosis, an open thrombectomy can be performed, or portosystemic bypass. Then, at the end of the procedure, actually in all cases, a relook should be planned to reassess the viability of the bowel that is still in situ. So how do we assess intraoperative bowel viability? Well, it all depends on the clinical signs. What do we see? What do we feel? And also the smell. First, pulsations. Are pulsations visible and palpable? What is the color of the bowel and the appearance? Peristalsis. And also if there's, in case of resection, when you, at the cut surface of the resection plane, there should be bleeding. Additional techniques to assess viability are a Doppler of the mesenteric vessels, but this is most of the time only on the greater vessels of the mesentery. And another option is also IV fluorescence and the inspection under an ultraviolet lamp. So this is for the patients with peritonitis. Now we move to if there's no peritonitis yet, we have some time for revascularization. First, the endovascular techniques, an embolectomy or thrombectomy can be performed, thrombolysis, an angioplasty or stenting, and in most patients afterwards, a post-interventional laparoscopy will be performed to assess the bowel viability. This is a meta-analysis that has been done, which compares the approach in patients. First, they assess the mortality, And there was a comparison of those patients who had a surgery first approach and those who had an endovascular or hybrid approach. And what they saw that in case of endovascular or hybrid first, there was a significant reduction in mortality. But it should be noted that in this meta-analysis there were no RCTs, so there might be treatment bias. Because if you have time, if a patient has the endovascular or hybrid approach first, it's probably, or it's likely that they had no peritonitis yet, and actually their prognosis would be better. So there is treatment bias. There could be treatment bias. They also looked at the rate of bowel resection, and also here there was a significant reduction in the rate of bowel resection in the endovascular or hybrid first approach. But once again, these were not RCTs. So then we go to the treatment of the non-occlusive mesenteric ischemia, the non-surgical management. Here it's important to address the hemodynamic instability and minimize the use of vasopressors. What can be done endovascularly is that a catheter can be placed into the artery with an infusion of a vasodilatory or antispasmodic agents like papaverine or prostaglandin to improve the visceral perfusion. And then last, the non-surgical management of mesenteric vein thrombosis, which is mostly of the time managed without surgery. First, the anticoagulation is very important, and only actually 5% of these patients receiving the conservative therapy will deteriorate. In these cases, a transhepatic percutaneous mechanical thrombectomy can be performed, thrombolysis or surgical exploration with an open thrombectomy and the bowel resection if indicated. So follow-up of these patients, if they, when they are out of the critical phase, smoking should of course be stopped, and blood pressure management and all the comorbidities and risk factors should be treated. Antiplatelet prophylaxis should be given with aspirin in case of occlusive diseases, and oral anticoagulation in case of atrial fibrillation, mesenteric vein thrombosis, or thrombophilia. So the take-home message of today are that acute mesenteric ischemia is a rare disease, but it often has a fatal outcome. The type of ischemia determines treatment. Early recognition is very important to enable this early treatment. And also here the interdisciplinary approach is the main factor, because to assure an immediate revascularization if this is possible. So thank you for your attention.
Thank you very much, Marit. Very comprehensive overview of this problem. Now we've invited our specialists whom we work with in this institution when it comes to treating patients with acute mesenteric ischemia. And I would just start the discussion by asking our specialists, how should we really proceed with these patients? Apparently there's some dispute, especially when it comes to the sequence of events or the sequence of treatments that we need to use following the diagnosis of mesenteric ischemia, especially should we go for revascularization first? Should we go to surgery first? Apparently peritonitis is one of the factors, but not always is it possible to assess peritonitis, maybe in ventilated patients. So when should we go for revascularization first?
Yeah, that's a difficult question. I think we have to look at it patient by patient. You know, if we look back, for example, we had that math professor recently, about 70 years old. He had been retired from the ETH and had a high CHAD score, but he stopped his anticoagulants like 2 months before and came at 3 o'clock at night to this hospital in acute pain, and had a CT, and we made the correct diagnosis, which is one of the problem. And I mean, in a case like that, where the situation is pretty clear, we brought into the angio and took that embolus out, and then we did laparoscopy afterwards, and everything was fine. And I think 1 or 2 days later, he went back home with his anticoagulation restarted. So that's an example case how I think endovascular first works, because often I hear from the surgeons that it's for them it's not that easy to see where the resections need to be done, you know, how extensive the ischemia is. And so I think, you know, this data, there's a not big series of patients, and but in my personal experience, I would favor, except we have air in the portal vein, and I mean, we see these cases. I mean, they're all median age. In our series, I think we published an article about 5 years ago, was about 80, and I think surgeons are not that eager to operate on these patients without knowing how well the ischemia will recover up front. Well, when you can do something, then I think for the operation, it's even probably, I don't know. I mean, you have to tell us that how well you can say the extent that needs to be later on. So I think that is not clear exactly which should come first, but I think we have to discuss that together, case by case, and see.
I have another question. Thank you for this nice presentation. And during the COVID-19 epidemic, we saw quite an increase of acute bowel ischemia, and you showed the first case with the fatality of a woman. Do we have any news about this? The pathophysiology, is the venous thing? Is it an arterial thing? How do we proceed? Is it different compared to the traditional ischemia?
COVID-19?
Well, I think in this patient it was a non-occlusive mesenteric ischemia, and she also had this cardiac arrest. So I think with her it is a NOMI, but with other patients we know that COVID-19 has an increased risk of also thrombotic disease. So most of the time patients will already, if they are treated in hospital, they will receive anticoagulants. She had prophylactic dose.
So on my list, there's 5 patients with COVID-19 associated mesenteric ischemia. All 5 of them had a fatal outcome. We're currently analyzing those, but there may be more in the hospital. Now, quickly, regarding diagnostic imaging, what are the findings that we can really rely on? Apparently, intestinal pneumatosis is not all that good a finding. What can we rely on? What do we need to look for?
Thank you. Thanks also for this fantastic presentation. Unfortunately, I believe that these numbers that have been shown regarding the sensitivity and specificity of CT are far too optimistic. This is by no means close to reality. We do every day these CTs, and in almost every CT we have problems to diagnose intestinal mesenteric ischemia. So 90–100%, that is absolutely not realistic. And there is something that really the people have to keep in mind. Pneumatosis does not mean ischemia. This is something which is also transported by, you know, opening slides, you know, acute mesenteric ischemia, and then a nice case with pneumatosis. By no means this is the case. We see, I would say, more pneumatosis cases finally operated, and the surgeons tell us there was nothing in the bowel. It was absolutely normal, than the other way around. So we have to be careful. This is a highly unspecific sign. And unfortunately, I cannot give you a solution. I just know that imaging alone is not specific and not sensitive in this regard. Unless we have free air or something like that, or it's very advanced and we have 5 signs plus foregoing myocardial infarction and hypotension and so on, then things become more clear. But imaging alone often is unfortunately not specific.
Thank you, Artem. And I think the next obvious question really is when we have those patients, we have to decide whether or not we have to go to interventional radiology, whether we have to go to the operating room. But my next question really would be is when do we need a vascular surgeon? What can vascular surgery offer to these patients? When do we need an open procedure? When it is endovascular?
To answer your question, I think in any case you suspect a mesenteric and acute mesenteric ischemia, in every case you need a vascular surgeon. So I think one of the big not why, because I'm a vascular surgeon, but I can tell you I think what the problem is. First, I tell you what I think that the problem is. Thank you for an excellent talk. I think most of or all of the topics, the interesting topics were mentioned, and what we heard is I think that the high mortality rates are a factor due to a very hard diagnostic finding to get to the right diagnosis. The problem that you have very only a few clinical findings, but and therefore you have a delay in time from when the patient shows up in the emergency unit, and then then the CT scans, and then the diagnosis, and until the patient comes to the operating room. That takes a lot of time. So the patients are treated at most often at a very late stage of the disease. And I think for a first endovascular approach, the numbers of patients are very limited, because you have to get the patient in a very early stage, and we don't get the patients in this early stage. And to put the patient in the angu suite and do the revascularization there, and then transport the patient into the operating room, that all takes time. And one of the big problems is also that with a laparoscopy, I think so you have to. I don't do that, but usually I think it's really hard. Most of the times the abdomen is already distended. You can get real view of all segments of the bowl. So when you decide to do a laparotomy, I think in any case you have to call the vascular surgeon, because, and I think this is the only problem in your presentation, when we can go please to the slide of the surgical management of the acute ischemia. I think before you here, prompt laparotomy and then resect clearly non-viable bowl. I think before you do the after laparotomy, you should do a revascularization of the bowl, because sometimes you really wonder after revascularization what bowl segments come to life again. Yeah. And also in laparotomy you have the possibility to do I did that several times, an endovascular approach with a retrograde stent angioplasty of the mesenteric artery. So I think this is a disease that should be treated in the hybrid OR and not in the emergency operating room, because you have much more possibilities of different treatments. Really, with endovascular approach, you should always do a completion angiogram. So I think, to answer your question, I think in every time you open up the abdomen, you should call a vascular surgeon first. And I really think that for the endovascular first approach, the patients we see too late, or the diagnosis is made too late. In some early stage, you do the revascularization because you only have very limited clinical findings, and then you do the laparoscopy. So you see some patients, but I think most of the patients are at a later stage.
So a very strong point for vascular surgery. I fully agree with the statement on laparoscopy. Oftentimes I find that very difficult to assess bowel viability laparoscopically. With respect to the intervention OR in the FOPS, I think there's more discussion that we should need to have with our logistics in this institution, which may go beyond this talk of today. But maybe one last question.
May I ask you something regarding the clinical management of the patients? Would you always recommend, after the interventional radiologists have done the revascularization, that we do a diagnostic laparoscopy, or would you rather make it dependent on the clinical setting of the patient?
Marit, do we always need to operate after revascularization?
I would say yes.
Do we always need to operate following revascularization?
I think the reality is different. The patient doesn't come with a stamp where it's written acute mesenteric ischemia. We usually get a question of suspicious mesenteric ischemia, and therefore we go for laparotomy. So if we know it before, then of course we do a combined approach. We go to Thomas, we go to Alexander, but usually we don't know. And as we heard, we often are wrong. So therefore, the reality is we open a 90-year-old patient and find either a disaster, black bowel, and we cannot do anything, I guess, or we find something which is nothing, and then we stop, or we find something which is rare, which we can treat. And then, of course, we should go in the hybrid OR, and of course, I would suggest that we go for laparotomy after revascularization and check. But the reality is difficult. I think we receive the call in the middle of the night. We have old patients very frequently, sick patients, and then it's difficult to treat them. If they have really mesenteric ischemia, the disease is highly lethal, regardless what we do. And I agree that we should combine a surgical approach, but the reality is at the moment different. We have frequently no approach to the emergency room. We have to wait. We have frequently to wait until we do the operation, and then it's often too late. And the patients are very sick, so therefore I'm not sure how to improve that. That's my only comment.
Final comment, one last comment.
Well, and I mean, there's clearly some mild and stronger ischemias too. I mean, we have to look up on that. We recently had a patient from cardiology. The diagnostic radiologist had missed an embolic event, an embolic occlusion, and she was there sitting in cardiology for about 5 days, not eating right, and eventually we took out that embolus, and then the day after she started eating. I mean, it was an embolic occlusion, and but she had enough collaterals by the inferior mesenteric and celiac trunk to keep her viable. So I think in a case like that, we can avoid laparoscopy.
Thank you. So I think we will continue to have some controversy on this topic, but we should come to an end. Thank you very much, Marit, for the presentation. Thank you for the lively discussions.